Hey there, this is Dr. Evan Osar, founder of Fitness Education Seminars, the movement-based solution to the healthcare crisis, and author of the Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. Thank you so much for tuning into this webinar. This is part 2 of a 3-part series on breaking the corrective exercise code. This webinar is going to look at corrective exercise as a way to improve hip function in your clients. So let's get started. We know lots of our clients present with hip pain and dysfunction, and we know there are many common causes, including muscle imbalance, prolonged sitting, and even age. But what really causes a lot of these problems in our clients? The biggest problem our clients that have hip problems are experiencing is an inability to properly centrate their joints, especially centrating and maintaining an optimal axis of rotation of the femoral head within the acetabulum. And oftentimes this is caused by gripping, too much posterior gripping of the superficial fibers of the glute max. And you see in this client here that presented with a labral tear, you see that posterior gripping of the superficial glutes and that hollowing or divot that's created when the femoral head is driven forward within the acetabulum. So this creates an anterior femoral glide and relates to very many of the common causes we see in our clients, including femoral acetabular impingement syndromes, or when clients get that pain when they adduct, flex, and internally rotate their hips, which also lead to many of the labral tears we're seeing. Most of the patients I'm seeing now that have labral tears have that anterior femoral position. Also, it leads to low back pain, SI joint pain, and degeneration of the hip joint itself. So, what's a common cause of this posterior hip gripping? Well, one of the most common causes we see in our clients and patients is poor stability in single leg stance. And you see my patient to the left who presented actually with low back pain. You can see why, is when he stands on one leg, he gets this hollowing and he drives the femoral head forward. So he's got to overuse the erectors and the QL and even the lats in the lower traps on this right side to create stability in a single leg stance. We also cue our clients, within the fitness industry, we cue our clients to use our posterior hip in a poor way when we teach them how to grip and drive the femoral head forward in the acetabulum through the common patterns such as squatting, bridging, and in this image here, deadlifting. Again, the client is over gripping their posterior hip complex and driving the femoral head forward and creating shear in the low back SI joint and shearing through the femoral head through the acetabulum. So, one of the best functional assessments we can do to help our clients or determine if our clients are experiencing this condition is the assessment of the core and hip relationship in single leg stance. When we stand in the single leg stance, we should be able to have a small amount of sway to get our weight onto the one leg, lift our opposite leg up to about 90 degrees, and we should see that the client is able to maintain their head and trunk over top their pelvis, and a stance leg stays straight. There's not excessive wobbling or gripping or anterior shear of the femoral head within the acetabulum. When we don't have a good ability, our clients don't have a good ability to stabilize and they have poor thoracolpelvic canister stability, it leads them to have compensated stabilization strategies. So you see in the client to the left, you see the common Trendelenburg's gait, where she stands on one leg and her hip kicks out to the side. These clients tend to have more hip pain and hip dysfunction. And in the image to the right, you see how she shifts her trunk up over top her stance phase or her stance leg. So she's overusing her lumbar erectors and QL on the left side to get the trunk up over top of that stance leg. These clients tend to have more low back pain and chronic trigger points of the QL and lumbar erectors because they're overusing their erectors, like I said, to get their trunk up over their stance leg. So what are we going to do about this? Our corrective exercise solution is going to take place in 3 parts. First, we want to release the stiff myofascial structures. So in the image to the left, I'm using a muscle energy technique and having the client really think about relaxing and letting go from our gripping. Oftentimes, the hip needs to be taken posteriorly. So as I do contract, relax with her and get her to relax the anterior hip structures like the TFL and rectus femoris and get her to relax through the posterior hip capsule and glute fibers, and as she contracts into my hand, I have her relax, use her breathing to relax and glide the hip back in the socket. Very effective technique with very little effort on either my part or the client's part. If you do not do manual therapy techniques, you can also use a foam roller. So a foam roller is really effective as well to get releasing of the posterior hip complex, the posterior capsule, as well as the rectus femoris and TFL. Again, you can use breathing and conscious thought to relax and let that hip complex go as you're foam rolling. Next, we're going to reactivate the thoracolpelvic stabilizers in two common patterns we use, the traditional bridge pattern as well as the modified side bridge pattern. The key here is we do not want to overgrip the posterior hip complex. We just want to use the glutes, lift up until the body is in a nice straight line along with the leg. We want to think about the legs going long, getting the weight out over top the feet. We want to make sure the client maintains core stabilization. I want to make sure they move through the hip complex almost like they're doing a hip hinge, and not drive the hip anteriorly, and they come back down. As soon as their glutes touch the floor, they raise back up. In the modified side bridge, another pattern to teach closed chain function of the glute medius. We have a client supported on her elbow and forearm as well as her downside knee. This activates those posterior glute fibers and lateral glute fibers, so we get great co-contraction of the entire gluteal complex. And now we also teach her how to use that thoracolpelvic canister stabilizers as she lifts up into the position. So again, we get activation of the thoracolpelvic canister stabilizers along with the gluteal complex, and we also teach that all-important function of dissociation of the femoral head and how to move that pelvis around a more static femoral head type position. Once we've accomplished this, now we teach them how to reintegrate this function back into their fundamental movement patterns. So again, in the image to the left, I'm performing a hip hinge. So another great way to start to teach your clients how to spare their spine, maintain a long spine, activate their core, and now hinge around that femoral head position. So I'm teaching the client how to stabilize their stance leg and pivot the pelvis around the femoral head. So it's a great dissociation as well as integration and movement. Doing a step up in the image to the right, again, you're going to align the hip, knee, ankle, and foot complex, and then you're going to teach the client how to drive off that forward hip and decelerate as they come back down into the starting position. Again, I want to have the client lift up on top of the steps and come back down eccentrically under control. I do not want to grip the hip at the top, and I don't want to lose that pelvic stability as you come back down through the eccentric phase. So in conclusion, we want to identify the areas of dysfunction in our client. As it relates to the hip, it's mostly a posterior hip gripping and a loss of centration. We want to teach the client how to improve their stabilization. So again, we'll use our release techniques, we'll use our activation techniques, we'll use a corrective patterning to improve the position of the femoral head within the acetabulum, and then we'll teach them how to integrate this into the fundamental movement patterns so they understand how to use it when they leave our session. This is an incredibly effective strategy for improving function in your clients. I want to thank you for watching this webinar and hope that it has helped you remain informed so that you can become the corrective exercise specialist your clients need and want. If you like this webinar and feel that it can help others, please feel free to pass it on to your friends and colleagues. We'll catch you next time where we'll discuss how to use corrective exercise to improve flexibility in your clients and without stretching. And we'll tell you about an exciting new product to help you develop yourself into the corrective exercise expert and leader our industry so desperately needs. This is Dr. Evan Osar of Fitness Education Seminars, providing you with the solutions and strategies you need to be the movement-based solution to the healthcare crisis. Take care. Have a great day.